Good evening, everyone, and welcome to tonight's information session, Voluntary Assisted Dying. I would like to start the meeting by acknowledging that we work on the traditional lands of many Aboriginal nations across Western New South Wales. I pay respect to all elders past, present and future, and acknowledge their continuing connection to land, water, culture and community. I extend this respect and warmly welcome Aboriginal and Torres Strait Islanders and Australians who are present in this meeting this evening. My name is Ali Sullivan. I'm part of the education team at the Western New South Wales Primary Health Network. Just a few housekeeping for tonight. Any questions, if you could please put them in the Q&A tab. We'll answer questions probably more towards the end of the presentation, but anything that we feel that can be answered during Jade and Tanya will address that. At the end of the webinar, we've also got a short evaluation survey, if you don't mind. It's a QR link, so you can just scan with your phone and please complete. It won't take too long. Now, tonight, I'd also like to introduce Gerald Chitsange. He's a facilitator for this evening. Gerald works at the Western New South Wales Primary Health Network, and he's a project lead for Collaborative Partnership Diabetes and the Voluntary Assisted Dying. Welcome, Gerald, and thank you for facilitating tonight. I'd also like to welcome and thank our presenters this evening as well. Gerald, thank you. I'll hand over to you now.
You're just on mute, Gerald.
Sorry. All right. Thanks, Ali. It's my pleasure to introduce our presenter today and the panel. So our presenter today is Professor Mark Arnold, who is the Voluntary Assisted Dying Implementation Lead for Western New South Wales Local Health District. And he also happens to be the Chief Medical Officer within the Western New South Wales Local Health District. Many of you would know him. He's got extensive experience as a rheumatologist. On the panel, we also have Jade O'Brien, who is the Voluntary Assisted Dying Project Manager. She is a registered nurse with over 20 years experience in clinical work, patient flow, project management, and delivering education. We also have Tanya Milsom, who is the Voluntary Assisted Dying Senior Health Planner. She's a qualified social worker with combined 20 years experience in case management, managing teams, health planning, and providing direct support to people experiencing grief and loss, as well as trauma. Without taking much time, I will hand over to our presenter, Professor Mark Arnold. Over to you, Mark.
Thanks, Gerald, and thanks everyone for attending tonight. It's always difficult with an evening meeting when we're so busy during the day and have so many commitments. I'd like to thank the PHN particularly for extending this invitation to us, because this is such an important topic, one which will touch all of us in our professional lives, if not in our personal lives, and one which it's very important that we understand where we're up to, because as many of you may be aware, we only have 69 days until the voluntary assisted dying legislation actually becomes operational on the 28th of November. So it's important for us all to know exactly what our responsibilities are as healthcare practitioners. And our purpose tonight is really not to be, not to try and convince you in any way or to try and change your opinions. It's really just a session where we can actually explain where we're up to with voluntary assisted dying locally, and what practitioners' responsibilities are, and some background about how we might actually think about beginning to work with the local health district in our individual voluntary assisted dying implementation pathway, as well as thinking about the New South Wales Health Ministry team. So I won't take up too much time because I'm sure there will be plenty of questions, but just very, very quickly, voluntary is actually one of the crucial words in this whole process. So people need to be able to have a suite of options available to them so that they can actually implement their goals of care for end of life. And people have been quite worried about voluntary assisted dying in the community. Our patients and many community members really aren't quite clear on the process. It does have also some history, as many of you are aware, and those of you who are like me or too many postgraduate years to count will remember problems in the Northern Territory, which actually has led to some of the legislation which we'll be talking about tonight, that actually initially prevented what at that term was called medical euthanasia. So really what we want to speak about tonight is the ways and means that a person who has capacity can actually make a request for voluntary assisted dying, and understand what their options are in their end-of-life care, and ensure that they are not coerced one way or the other into an end-of-life path that's not optimal for them. So I want to emphasise that there's an enormous amount of governance, and there's a particular stringency about how people may access voluntary assisted dying. And right at the moment, they can't access it, of course, because the legislation actually doesn't implement until November. But I want to give you some background, and we can have some discussion later about how this is all going to take place. So if we could have the next slide. So a person who's approaching their end of life needs to be provided with the best quality care we can give them, and that's regardless of whether they live in a metropolitan area, a regional town, or a rural and remote site. So that's our challenge that has been that we're asked to implement at the local health district, so that we can give the best end of life care for all of the people across our vast footprint. Next slide, if we can. Yep. So the aims are really, I'm sure you've all considered your own position on voluntary assisted dying, and you know whether you support or whether you don't support. Tonight is really not what we wish to talk about. What we really need to cover tonight is what health practitioners' rights and responsibilities are, and you know how you can think about being involved if you wish to be involved, and if you don't, how you can go about still dealing with patients, because we will have to. It's really important that we know our obligations within this legislation, and I hope that will become clear. So if we have the next slide, please, Owen. So many of you are aware, and I've just mentioned the implementation date of November, and the Act was actually debated in Parliament last year. So there's been a fairly long implementation time to actually get things going, but it certainly is all happening with a rush. As you might imagine, all of our local health districts across the state have their own challenges to implementing voluntary assisted dying, and each month all of the implementation leads meet to actually discuss how we're going with our progress, and we're making sure that not just a metropolitan voice but a rural and regional voice is being heard by the ministry when we're actually implementing the practicalities of voluntary assisted dying. So it's been a huge amount of work, and I'd just like to acknowledge Jade and Tanya's tremendous work that they've put in over the last few months to make this such a sound program that we will be able to implement at the end of November. So eligibility, again, I'd just like to emphasise the stringency. This is not for children. So unfortunately, children with terminal conditions, brain tumours, so on and so forth. This is not for them. The people who are eligible to access voluntary assisted dying have to be an adult. They have to be an Australian citizen or resident in Australia for 3 continuous years, and in fact living in New South Wales. So it's quite important to understand that, in our areas across our state where we border Queensland or we border South Australia, Victoria, many people actually have care that crosses across state boundaries, but voluntary assisted dying does not cross across state boundaries. You have to be a New South Wales resident, and it has to be implemented here, and we can't have cross-jurisdictional voluntary assisted dying. The basic premise is that the person has to have a definitely lethal condition, which will likely account for them within 6 months. And generally this is in the setting of cancer. It could be, of course, in the setting of respiratory failure and many other conditions. So what one has to be actually quite sure about the prognosis, that they're not likely to live for more than 6 months. The exception, of course, is people who have neurodegenerative disease, and the obvious example is people with motor neurone disease and bulbar palsy and respiratory failure. So nuts and bolts, 12 months for a neurodegenerative disease and 6 months for a non-neurodegenerative disease. How do we actually make that assessment? Well, we'll get into that later when we're talking about the consultation process about assessing patients. But it's crucial to understand that people need to have capacity. I mean, we need to have capacity in all aspects of thinking about healthcare, consenting for surgery, so on and so forth. But this is one area where decision-making capacity has to be absolutely crystal clear. And this will be one of the areas where families will be quite distressed because the issue is that the person who's actually requesting voluntary assisted dying needs to retain their capacity throughout the process up to the time of administration of the voluntary assisted dying materials. So unfortunately, people who are dreadfully afflicted by Alzheimer's disease, who don't have capacity, it's not possible for someone to actually use guardianship to access voluntary assisted dying. The decision has to be the individual's decision. And they have to be acting without duress. So when we're assessing a person, that we have to be sure that there's no undue influence from family or friends, one way or the other, in the decision-making process. And importantly, people need to be able to communicate their wishes throughout the process. So there may be people who aren't vocal, and that's a challenge to assess capacity in that situation, in which case we will need a formal capacity assessment, which we can get onto later. So if we can have the next slide, please. So capacity is defined fairly clearly in the Act, and I won't read it all out because I've covered it to some extent. But really, the capacity to make a decision about ending one's life is, it has to be very clear, and essentially the person needs to be able to indicate to their practitioners that they fully understand that they are potentially taking a step which will end their life should they wish to consume the oral option, the self-administration option, or should they wish practitioner assisted administration. They have to retain capacity throughout the process. So in the final moments when someone to swallow the pharmaceuticals, we still need to be sure that they have capacity, and prior to an administration of an intravenous preparation, again, capacity needs to be clear. So we need to understand that people can weigh up the pros and cons and that we can be sure that they actually understand that voluntary assisted dying is not their only option. They have access to palliative care, and they have access to refuse either voluntary assisted dying or palliative care should they wish. Capacity, if a capacity decision is needed and there is concern about whether a person has capacity, the requirement is that either a psychiatrist, neurologist or geriatrician makes an independent assessment. That will come with its challenges in our areas, as I'm sure you're all aware, but capacity assessments, at least in the interstate experience, not that common, but again, we can talk about this. Next slide, thanks, Ellen. So, can we actually talk about voluntary assisted dying with a patient at the moment? Well, yes, we can, as long as it's part of a discussion which actually looks at all of the possibilities that a person might wish to exercise in their goals of care towards the end of life. So it can't be an exclusive conversation. And of course, it can't be a conversation about the materials themselves, because we're not at liberty to discuss those materials right now, and I'll explain that in a moment. It pertains to the legislation. But certainly if patients are asking, they will come along to your office and say, look, I understand that towards the end of November, I may be able to access voluntary assisted dying. What's it all about, doctor? Well, hopefully this session will give you some background that will inform that discussion. It's important also to know that there's a suite of materials that you can access through the Ministry of Health, and they'll be replicated locally through our local care navigation service when that actually stands up. So the next slide, please, Ellen. Conscientious objectors. Well, look, we understand people have definite viewpoints about whether this is appropriate or not appropriate for them to participate in. I would emphasise it is the law of the state, and so we're in a position where we can't refuse patients access to a legal treatment, and there are precedents for that. So if you are someone who has a conscientious objection, you do not have to participate. However, what you need to be able to do is to explain to your patient that you will not participate, but you need then to actually have a pathway to refer that person along so that they can actually have the discussion, and if they wish to start the process happening. And so we will be able to explain later that we have a local care navigation service that you can contact via phone or via email, and there is also a statewide care navigation service. So it is important to understand also that if a patient makes a clear request, it needs to be documented in your clinical notes, and you will need to actually record that the patient has made that request, and there will be ways of actually recording that through an online portal. The online portal will work for people who are actually voluntary assisted dying practitioners, who will have access to different aspects, but anyone who has a conscientious who is a conscientious objector will be able to go to the portal, fill in the appropriate materials, and then be able to discharge their responsibility. So the responsibilities I've more or less covered in advance. It isn't appropriate to try and dissuade someone about voluntary assisted dying. Again, it's reasonable to have the discussion about the suite of options available for end-of-life care, but if a person makes an unambiguous request, that will need to be recorded in your notes, recorded on the portal, and from there on in, the patient can be channeled to people who are in a position to deal with that request. The other issue too is that routine care that's going to be given for people who are towards the end of life can't be withdrawn. So if someone is accessing voluntary assisted dying, it's still our responsibility to continue to look after them as we would normally do with our normal clinical care. Now, if we can have the next slide, thanks. So defined roles in the voluntary assisted dying process. So it's important to understand that this is very doctor-centric, certainly in the initial phases. The coordinating practitioner is the person who actually conducts the first eligibility assessment for a person who's making a request about voluntary assisted dying, and thereafter coordinates all the steps. So if you have done the training, if you elect to do the training, and you have a patient who makes a request and you're in a position to agree with that request and then process that, you will become the coordinating practitioner. And that will follow through the process of voluntary assisted dying until administration. The requirement of the coordinating practitioner is really to quartermaster all of the materials, contact the voluntary assisted dying board through the portal after arranging for consultations with independent practitioners who will make an assessment about the person's prognosis, their underlying disease process, the likelihood of death within the next 6 months for an oncological condition or 12 months for a neurodegenerative condition, and that consulting practitioner will then give their report, and the coordinating practitioner will forward all the information to the voluntary assisted dying board, who will then decide on the appropriateness of being of a practitioner being allowed to prescription for either self-administration or practitioner administration of the relevant substances. The administering practitioner doesn't have to be a doctor. It has to, but it is either a doctor or a nurse practitioner. And what's the seniority? Well, to be a coordinating or consulting practitioner, you have to have had general registration for 10 years. And as an administering practitioner, 5 years, general registration, or be a registered nurse practitioner. So if we can have the next slide. Eligibility. Again, I'm getting a little bit ahead of myself here. The registration guidelines I've mentioned. There is approved mandatory training, which is being rolled out by the ministry. We have a session in Dubbo on the, unfortunately, on the day that there is the referendum. We are conducting that in the offices at Commercial Avenue, and Tanya and Jade will be able to tell us whether there are any further available places. But if you did wish to come along, you would need to vote in the referendum with a postal vote. So just mentioning that as a slight advertisement. There is also online training that you can undertake, which will be rolled out by the ministry in due course for those who can't attend but still do want to undergo the relevant training. But it's important that you have no relationship to the patient, and you need to be in a position to be able to be sure that you're not going to have a material benefit from that patient's death. And this is fairly obvious. And there are no other amendments to the qualifications that seem likely in the legislation at the moment. So fairly clear about who can or cannot be a voluntary assisted dying practitioner. Training, it will go live through the portal. If you are interested in doing the training, we can send you the relevant link. You may have seen this already. Essentially, all you need to do is have your APRA registration number, go into PRODA and get your HPI number. I mean, I obviously remember my HPI number off by heart, and my APRA number by heart. You need those two bits of information. You also need two items of identification, the usual things: passport, driver's license, and you need a CV. You upload those, and then your application will be assessed. My application is being assessed at the moment. If we can have the next slide. So what's the process? So, well, it's it looks a little bit involved, and every time we discuss it, it just sounds as though it's somewhat Byzantine. But the nuts and bolts is that the process starts with the patient, and this is a very patient-centric treatment. The patient makes a first unambiguous request to a practitioner. If they're in a position to agree to that request and become the coordinating practitioner, they then fulfil that role, assuming they've done the training. They arrange for a consulting practitioner to independently assess prognosis, likelihood of death within 6 months, make sure there are no areas that need clarification, and also this is where the capacity assessment comes up. There then needs to be, rather than just a verbal request, a written request from the patient with a final request and a final review. The board then becomes involved. Who are the board? They're people who are not named for clear reasons, but they are medical practitioners, people with legal qualifications, and community representatives. They check that the appropriate steps have been fulfilled. There are no questions, and they can then authorise the administering practitioner to write a prescription for either oral or IV administration. The materials are supplied through Northern Sydney Health Service through their pharmacy there, and we don't actually deal with that through our local pharmacies. It's certainly not a community pharmacy exercise. Central Pharmacy Service ensures that either the administering practitioner has the materials, or that they will be able to pick them up, or the patient will have the materials for oral administration sent to them. So where can the substance be taken? It can be taken orally at home or in a healthcare facility, aged care facility, hospital. Any option is possible. Practitioner administration at home is possible, or at any facility is possible. Once the materials have been administered, either self-administration or by the practitioner, the process takes its course, and any materials that are not used any other materials that are left have to be disposed of in a particular way. They are sent back to our local pharmacies, who are then authorised disposers. The patient has a nominated person who will actually contact the disposal service and ensure that some other aspects of the paperwork are sorted out, so that clearly the materials can be dealt with in an appropriate chain of custody. So the next slide, if we could. So the Criminal Code Act. So I'm sure many people will remember Dr. Nitschke, and this is where this came about. The Criminal Code really prevents us discussing either on a telephone, on a video conference, or any mode other than face-to-face, the particular pharmaceuticals that are given to people that will result in voluntary assisted death. That discussion must take place face-to-face. Other discussions can take place via, for example, telehealth. And we understand that this is going to pose challenges for some of our people in our remote rural locations. So there is flexibility in how the discussion takes place. But once we're talking about administration, whether self-administered, practitioner-administered, oral or IV, and any other information related to that must take place face-to-face. So that discussion needs to outline the clear consequence of being administered or taking the substance, and also making a plan about how their assistant person will actually deal with matters after the administration of the materials. If I could have the next slide. So the board, I've mentioned, they're there for governance. They're not there to really be another review panel, apart from ensuring that all the relevant governance steps have taken place. In interstate jurisdictions, similar boards are very rarely in a position where when the information has been sent to them, they're not in a position to refuse. But the board also maintains a list of people who are authorised voluntary assisted dying practitioners, and that's their other role to ensure, if you like, that the credentialing of people with voluntary assisted dying has been undertaken appropriately. So if we can have the next slide. The online portal still being established, and there are a number of steps that are still happening furiously in the background, so that we can make sure that you all are aware of how to contact the State Care Navigation Service if necessary, or preferably our local Care Navigation Service. The portal really is how people who are voluntary assisted dying practitioners interact with the whole process, and everything will be uploaded through the portal. Training will be provided, and you will only get access to certain areas of the portal if you are an authorised practitioner. But as I mentioned before, people who are conscientious objectors will still be able to access the relevant materials that they need to register that they will not be the coordinating practitioner and wish to hand that responsibility over. Next slide. So what's a Care Navigation Service? So there is a state Care Navigation Service, again out of Northern Sydney through at North Shore, and there's our local service. So what's really the difference? The difference is that our local Care Navigation Service will clearly be in a better position to understand the geographical implications of a person's request, and how we coordinate their various assessments, and how we coordinate their administration and the disposal of the pharmaceuticals afterwards. We've been very careful with our design and our model of care to ensure that it is patient-centric, and it really actually understands the issues that we have with our geography and our very dispersed population. So how is this going to work? When you actually want to get access to the service, what happens? So if we have the next slide. So there is the state service that will provide, in some instances, a fly-in and fly-out service, and there are some areas where that will be needed and will be appropriate in some circumstances. But our local service is a dedicated team. We will have a full-time Care Navigation Service coordinator, and we also have a position for a part-time VMO GP practitioner who will be able to act as the care coordinator if the patient's practitioner is not willing to fulfil that role. That person will likely be able to be an administering practitioner, and again, there will be circumstances where they may or may not be able to administer, and we may sometimes need to have access to the state service. But the modelling that's taken place from interstate and that we've done locally suggests that this will give us pretty good coverage for the anticipated number of requests that we will be having. Next slide. So it's important, I did mention the statewide pharmacy, so clearly these are materials that need to be carefully administered. The substances are up there and I won't read them out. The statewide pharmacy's role is to ensure that the pharmaceuticals are distributed to either the patient for oral administration or the practitioner for IV, and also to provide education and support for patients and voluntary assisted dying practitioners. So in other words, there will be a pharmacist who will go out to ensure that the person accessing voluntary assisted dying has the materials, and we have a chain of custody that's established. The next slide. So what's the process? So one pathway might be that it happens entirely through the state service. As you might imagine, we may be in a situation where it's just not possible within a reasonable time frame for people to be able to access our local service because they may be assisting other patients. The important thing to understand about the process is this is not an acute service. As you can see, there are a number of steps that are required by legislation to be undertaken. And looking at interstate experience, the average is at least 10 to 14 working days, even when we're being pretty speedy in getting the process underway and ready for administration. It is not an acute service that happens at 2 a.m. in the morning with someone attending accident and emergency or an MPS. This is something that will happen during working hours, and that will pose some frustration for patients, but it needs to be done with the appropriate level of governance, and that's really the only way that we can do it. So there may be a completely external service. There may be a hybrid model, which with two of those, the partnership with GP and specialist and our service. So in other words, if those of you who elect to be a coordinating practitioner, we will work with you locally, even if you're not working in the LHD or have an appointment with the LHD. So our role there is to help you. There may be a completely internal service where we undertake the care of the patient with our GP VMO as the coordinating practitioner, arranging consultations and then administering, or sometimes utilising the state service. But we see the state service as really a situation where it will be necessary for administration on occasions where it's just not feasible to have our practitioner or practitioners in Gaduga and arguably down in Condobolin. So there we are. Next slide, if we could. So safeguarding, I've mentioned it's not an acute service and things happen in the cold, clear light of day. And I've mentioned before that the patient needs to retain capacity throughout the process. And so we may end up with situations where people are deteriorating and they do lose capacity. And that's dreadful if they do, but if they are not in a position to actually understand what's going on, if they have a delirium, for argument's sake, let's say they're admitted to hospital with urosepsis, and it seems that it would be appropriate to as part of giving comfort measures, would the next issue be giving their voluntary assisted dying substance? Well, the simple answer is no, because if they're delirious, they don't have capacity. So there are, we foresee that there are going to be a number of situations where our local care navigation service will need to discuss any acute deterioration of a patient to ensure that we can be clear that they retain capacity throughout the process. So not turning up at 2 a.m. in the morning, which is something that has exercised our ED colleagues a little bit. Private residential aged care facilities, whether they do or don't have a religious orientation, may or may not be involved. It's their right. If they don't wish to be involved, they can't prevent access to the process. So in other words, reasonable access of practitioners care navigation service assessment and voluntary assisted dying substance. So that has been that potentially is a problem, but I would say that Tanya and Jade have been have had a tremendous geographic coverage across our district with really all of our facilities, so we're well placed to know what people's intentions or what facilities' intentions are at the moment. And next slide, thanks. So resources, so there's still resources being developed. There's obviously handbooks for practitioners. There's information which is provided to patients, which is in very clear English. In some circumstances, perhaps not many for us, interpreters might be necessary. Pharmacy support information, booklets, and really fact sheets about how to undertake the appropriate declaration, so on and so forth. There's also some changes to the death certificate and notification of death paperwork that's happening as we speak. So as it is at the moment, it would not be possible. You can't record voluntary assisted dying now because it's not legal until the 28th. But there needs to be a way of acknowledging this in a death certificate, so it doesn't appear to be a suicide. Next slide. So just quickly some scenarios, and we can cover these, and I'll quieten down soon so that we can have some discussion. So one scenario which is fairly obvious, middle-aged lady meets eligibility criteria, let's say metastatic melanoma with multiple metastases, hypercalcemia, so on and so forth, meets the eligibility criteria by having capacity, request voluntary assisted dying in an appointment, and their GP is the coordinating practitioner. Straightforward. What's not straightforward, and which things which will, or situations which will cause difficulty, for example, an elderly patient who's gone through the voluntary assisted dying process and has the substance, but in consultation, the GP is concerned about their decision-making capacity. So a capacity assessment would need to be made, and unfortunately, if that person does not have capacity, they would not be able to use their voluntary assisted dying substance. So we don't then go in and seize that substance, but the way to deal with this in the appropriate legal framework is still being developed. A situation which is equally clear as Sally's situation, an elderly person with dementia recently diagnosed with a lethal condition, and the family are requesting voluntary assisted dying. Well, as we've said, it's only the individual who can request voluntary assisted dying. So unfortunately, Bill does not have capacity, and he can't have a substituted decision maker requesting voluntary assisted dying. And I think that's the end of our suite of slides, with any luck. Oh, local inquiries. If you do get any inquiries from media, this is more to do with facilities. Please direct any inquiries that you might get from local papers, for instance, to media at Health New South Wales or the ministry itself. And I think that's the last slide. Far West. Chelsea Edwards is dealing with any issues in the Far West. So any of you who have a practice footprint that's there, Chelsea, can be contacted. And there's the website. This is an emotive discussion. If you do have concerns, we'd recommend that you contact the appropriate facilities if you are distressed by any of this discussion. So look, I'll stop there and open it up for questions.
Thank you, Mark. There have been some questions coming through the chats, and I think they've been responded to. Does anyone have any burning questions to ask?
Probably clarify, Gerald, it's Jade, that I've answered all the questions enough for the people that have asked. Particularly Christopher's question. I just want to make sure that I've answered that well enough for him.
Right. Christopher, are you happy with the answer you've received in the chat? Or do you want further clarification to your question? Christopher Hayward.
Christopher's saying he can't see the reply. So the question was, can you please explain the limits of the role of the patient, long-term GP, if I have not had full registration for 10 years? For example, how much will we be able to continue to play a role in the care of the patient when we can't be a coordinating practitioner? Are you happy to answer that, Mark?
Yeah. So Chris, you would continue to provide regular care. So the coordinating practitioner is really just dealing with the issue of voluntary assisted dying, and the understanding is there would be a dialogue between people so that the patient's looked after. So GPs won't be excluded from care, and we certainly don't want that to be the case, because they still have other health needs that will need to be dealt with.
Got another question from Lisa. Question around concerns for residents at certain residential aged care facilities which restrict conversations between practitioners and residents around VAD. How can they be assisted?
Well, that's where our care navigation service would really come into it. I mean, if they're it's tricky because if we're talking about a GP visiting a residential aged care facility and that their regular GP and the patient wants to have that discussion with their GP, well, it's tricky, but technically they really can't impede that discussion. But the sensitive way around that would be to direct that inquiry to our care navigation service, and then we would liaise with their GP offline and work out how best to go about that problem. But yeah, we accept that it's going to be tricky.
Yep. Christopher's follow-up question is there a formal process of discussing the cases with the treating GP?
Well, yes, that's the intention. So the thing is that the coordinator, so let's say if the treating GP is not the coordinating practitioner, the coordinating practitioner would need to have access to the clinical record of that patient, and that would be not only simply the relevant medical records, but it would be an appropriately informed discussion, a verbal discussion, so that would really also give some context to the likelihood of this person, the motivation behind the person's request. And also the GP is usually best placed to know their prognosis and their other issues, their comorbidities. So yeah, not excluding Chris, and the more we know about the person, the better, and then we can make that a better decision can be made by all people involved in the process, and then it's not likely to be open to challenge, and it would make the voluntary assisted dying board's decision about whether to allow a prescription to be written can take place.
So Karen asks, is there a certain number of days from the initial notification of intent and to the administration of the lethal substance?
Yeah, so it's, is there, in other words, is there a cooling off period? Well, the person, because they have capacity, can actually decide, at any time in the process to put a stop on the process or to exit from the process. So we do anticipate that people will actually have their voluntary assisted dying materials for self-administration, and they may decide that they don't want that, and they may wish to then access palliative care, and that will be part of the coordinating practitioner's role to think about that. But the practicalities of it are that interstate, the amount of time that it takes to actually obtain all the relevant clinical information, synthesize it, upload it to the portal, is a number of hours. That needs then that's one process. Then the arrangement for a consulting practitioner to actually review the materials. They don't necessarily need to physically consult with the patient. There will be a delay in that, and there will be a delay in the decision of the voluntary assisted dying board. So you would think that it could potentially take place within 5 working days, but we all live in the real world, and we know that nothing happens that rapidly when we're trying to interact with a bureaucracy and trying to organise other doctors to do things. So interstate, realistically, it ends up can be a 10 to 14 day process. That's probably the minimum, and it can take weeks. It can take 6 or 7 weeks for people to actually make a decision, and they can halt the process at any stage.
Lots more questions coming through. So Maria wants to know what the role of RNs in residential aged care if a resident wants to know more about VAD. So as an RN, you can give information as long as you feel comfortable and you have the knowledge to do that. If a person is asking for VAD, as an RN, you need to know that you need to escalate that to a medical practitioner. There is. Where else can we get training? So there's the Dubbo Day. There are days in Sydney. There's probably only 5 days I think they're offering face-to-face. Otherwise, it's online. So if you go through the registration portal and give your details, they send you an email after they go through your eligibility criteria, and they'll have further details about how you would do the online training. Karen wants to know, does VAD cancel life insurance? From what I've been told, no. The medical certificate of cause of death will be reflective of that person's medical illness or condition. Will there be discussion with the existing teams? I have heard stories from interstate of community health teams not being aware their patient had applied for and died by VAD, which makes me worry that the existing team was not being included in the assessment of the suitability.
Yeah, this is one of the roles of the person that the patient will nominate to deal with matters after their death. So it's one of their responsibility to notify other doctors and other people of the person's death. But I think what we're really talking about here is that we do want people who are involved in the patient's care, to be aware of what's going on. So I mean, we all know it's dreadful to be blindsided when someone dies in hospital and you haven't been informed by the team that person's died, and of course you'll meet their relative down at the shops the next day. So no, we do want to make sure that this is conducted in an appropriate way that doesn't marginalise people in the treating team out of the process.
And there's just another saying, will it be implemented in aged care facilities? So yes, it can happen at home, in aged care facilities, or within any of our facilities within Western New South Wales Health District. I think we've got through the questions.
Okay, thank you. Jade, that's all the questions?
I believe so, yes.
Oh, thank you for that. Thank you, Mark. Thank you, Tanya. Thank you, Gerald. I've just put the evaluation QR code up on the screen. It's also, I think, in the chat as well. A link there, if you don't mind doing that, would be much appreciated. Thank you, everyone, for joining tonight. Thank you to our panel, our facilitator. Very much appreciate all your time tonight. I'll just leave the evaluation up for a bit longer, but feel free to leave as you wish. Thank you.
Yeah, and I mean, just a final word, please feel free to contact us, the voluntary assisted dying team. If there are questions that we can answer, that you'd like us to answer, please let us know. With these sort of complex situations, often it's something that will come up with a bit of reflection later on. So if you do have a question, please tell us.
Yeah, and we'll definitely share contact numbers with you when they're existing. So I'm sure the PHN will pass that on to everyone as soon as they're available and we've supplied the details.
Yeah, sure. Jada can pass those on. Thank you. Okay, I've got one last slide. Thank you.